we will open this with the greeting speech from our executive chairman, Dr. Sutoto. Please.
Good afternoon, dear KARS webinar. Today, as always, KARS are going to fill your time at work from home with precious lessons learned from other country to broaden our mind and knowledge. Today, we have the luxury at the presence of two experts from Australian Council on Healthcare Standard International. He is stationed in Sydney. I welcome my best friend, Mr. Mike Giuliano. Hello, Mike.
Hello, everyone. Thanks for having me.
One of the chairman of Australian Council on Healthcare Standard International, who is going to teach all of us the Australian experience in COVID-19 handling. And the second expert will be our dear Associate Professor, Muhammad Abdul Kadar Marikar, Executive Officer of Malaysian Society for Quality in Healthcare. Professor Kadar will present about his country's experience also in COVID-19 handling. Here, KARS webinar, KARS will always put Indonesia's spirit up with always positive thinking and being optimistic. With this, we hope Indonesia will always growing upward and toward the future. After presenting expert from Joint Commission Taiwan several days ago, KARS will present to all of you experts from all over the world. I do hope you will enjoy today's presentation of these two experts. Okay, Dr. Hani, time is yours.
You.
Good day.
Thank you. We will ask Michael to start this presentation. Thank you.
Great. Thank you, Dr. Sutoto and Dr. Hani, for inviting me to share the Australian experience with KARS and your KARS family. So hello to everyone who is on the call as well. And thank you to also my other panelists, Dr. Kadar. Hopefully you're doing well in Malaysia as well. And nice to see you virtually and hope you're doing well there. So I will just share my presentation. Just give me 2 seconds. Okay, can everyone see this okay?
Yes. You can click the open to open full. Yeah.
Perfect. How is that? Good?
Good.
Good, yes.
Great. Okay, so thank you everyone for joining on this Friday afternoon. Dr. Hani has reached out to me from Australia to provide some lessons learned and experiences that we have been undergoing, obviously, in response to COVID-19. So I understand that obviously everyone in Indonesia is working from home, and hopefully everyone is staying safe with the continued outbreak and management of the virus. So what I'd like to do today is share with you the background about ACHS International, just so you know where we are coming from in terms of an organization, share Australia's journey through COVID. I'll bring you through a few facts and figures about how we have been hit by the virus, and then subsequently how we managed to bring down the number of cases. Also highlight with you the impact on our domestic and international accreditation services, because we have been impacted differently in different ways, and also showcase some innovation that we've come up with during COVID. So I always like to end on a positive note and share with you some positive things that have actually come out of this time from working from home and taking a pause from our daily business activities of doing accreditation. Unfortunately, Dr. Lina Loh, who is our Executive Director of Corporate and Assessor Divisions, at the last minute had another competing meeting, but she does say hi to everyone and send her apologies for not being able to make it. So I believe we'll take questions at the end, Dr. Henny. So I'll go through this information, and then Dr. Kadar and I can take any questions at the end. So just a really quick overview of healthcare in Australia. A lot of research actually shows that the Australian healthcare system is one of the best performing in the world. So we're quite lucky here to enjoy a healthcare system which provides free access to all patients, whether or not they are citizens or residents living in Australia. And we operate on a hybrid healthcare system here in Oz, which means that everyone has free access to public healthcare, which ranges from acute services to non-acute services like dental, optical, aged care, day procedures, etc. And we also have a private system where you can use your private insurance to skip queues, to have faster elective surgeries, private rooms, etc., within a private facility. This is really just a foundation to speak about how our response to COVID was quite successful, given the fact that we're working in a public and private system where we're able to shift capacity quite easily. And I'll talk about that in a little bit. Just a quick background on ACHS. ACHS is, like KARS, an ISQA accredited provider. We have been since the 1990s. ACHS stands for the Australian Council on Healthcare Standards. We were actually founded in 1974 by healthcare professionals from the Australian Medical Association and the Australian Hospital Association that came together to say, well, we need a set of standards for the way that we will provide safe quality service in any aspect of healthcare throughout Australia. So our founding has been quite long and over 40 years of service now. Unlike, I believe, KARS, we are completely independent from the government, and I'll speak about this a bit later. So we're not government-funded, independent, private, not-for-profit organization. And as I said, I'll discuss the impact to our domestic and international businesses and what that means for us in Australia. Here we're the oldest and largest quality improvement agency with over 1,500 members. In Australia, unlike in Indonesia, we actually have government-enforced competition for accreditation to the national standards. So hospitals here must be accredited. All healthcare services must be accredited, but they have a choice of 7 providers that have been approved by the government from which they can choose. ACHS is one of those providers and is by far the largest and oldest, as I mentioned. And that obviously has an impact on us, which I'll discuss a little bit later. In our name, you can see Australian Council. So in addition to a board, we are also governed by a council of representative peak healthcare bodies that you can see here, from consumers to medical to nursing to day procedures, private and public, etc. And this has come in certainly very useful for us as we are making our response to COVID and then trying to quickly adjust to how we manage our services. This is just a quick reminder about ISQA, so we're all on the same page here in the ISQA family. This is also just a quick background on ACHS International, which is a separate subsidiary company to ACHS, basically to export our Australian standards, our accreditation scheme, and quality improvement systems to the rest of the world. We work predominantly in the Middle East and in Asia, with over 100 members across those regions, operating in 15 countries with 400 assessors, about 300 of those based in Australia, and 100 of those based throughout the Middle East and Asia. So with that coverage, obviously, we have additional impacts from COVID on our accreditation operations to deal with the differing impacts and severity of how the virus has affected many different countries in which we operate. We also provide lots of different products and services besides for accreditation or quality programs. We also have consulting and education programs, which we have moved all online in response to the ban on travel, which again, I'll talk about in a little bit. And also our performance and outcome service, which is the world's largest international benchmarking service for clinical indicators, which has been online already. So that has been a seamless transition as we responded to the new virtual world in which we live. So I wanted to provide that foundation because it does inform how ACHS in Australia really has responded to the COVID crisis. In this second part of the presentation, I'd like to take you through some facts and figures and a bit of a journey about Australia's response to COVID. First off, I just want to share with you the snapshot from yesterday. So this is live data that can be accessed at any time by anyone throughout the world on coviddata.com.au. As of yesterday afternoon, we had 11 new cases, which was an increase from 11 from the prior day. So total since the outbreak has hit, we had 7,150 throughout all of Australia. This equates, unfortunately, to 103 deaths, with one death actually occurring recently on Wednesday. Great news, though, that we've had 21 recoveries yesterday, which equates to 6,583. So there's a huge proportion of people who, unfortunately, were infected with the virus but are quickly recovering. At the moment, we have around 550 still active cases, but that is of various levels of severity and asymptomatic or symptomatic cases. Majority of those are not in hospital, thank goodness, as our ICU occupancy has been coming down with COVID cases, which is great news. You can see at the bottom a summary of the state and territory reports about the number of cases, deaths, and recoveries. I live in a state called Victoria, which you can see in the box here, where Melbourne is located. Even though Victoria has been performing very well and is one of the strictest states in Australia in terms of the COVID restrictions, you can see here, which is a little bit interesting, why our cases seem to be highest amongst the other states, which actually have had looser restrictions than ours. And the explanation there is twofold. One is obviously we are one of the largest metropolitan areas in Australia, so much higher density like Sydney than compared to the rest of the country. But second, Victoria has invested in what we call a testing blitz. The government has indicated they want 1 million people tested over the past few weeks to ensure that as we start to ease restrictions in the country over the next few weeks, that we are understanding if there are things like sleeper cells. Basically, are there pockets of viruses that are asymptomatic that we don't know about yet, but need to find out before we start letting people interact and easing of social distancing. So through this testing blitz program, Victoria has actually found some pockets in the Melbourne area, particularly in workplaces that were continuing to operate as essential services, that found people who were asymptomatic but were actually testing positive for COVID. And subsequently, they have gone into isolation to prevent the further spread of the virus. So I just wanted to tell a little bit of that story in terms of this data from yesterday to give you a little bit more flavor about actually what's happening here. Now, of the 103 deaths that we unfortunately have had in Australia, an interesting question comes up about where they're coming from. The majority that you can see here actually came from cruise ships or aged care facilities from people who have traveled abroad. So someone who was internationally, whether or not they were Australian citizens or not, and coming to Australia and basically importing that virus and spreading that throughout the country. You might have seen in the news a lot of controversy about the Ruby Princess, which had many infected COVID patients on board and docked in Sydney Harbour, right next to the Sydney Opera House. And those patients were allowed by New South Wales Health to disembark the ship and go back to their homes if they were citizens or residents. Some of them were not picked up on testing, and then subsequently, through that release to the community, you can see that they've had one of the largest impacts in terms of spreading the disease, spreading the virus throughout New South Wales, and then causing quite a lot of deaths in elderly population. We actually had a hotspot here in Australia, or basically what people are calling the epicenter of COVID in Australia, in Sydney, and that was first detected back in March, April time at a aged care facility called Dorothy Henderson Lodge in Sydney. So we were seeing a spread of COVID throughout elderly patients, from visitors who at that time were still allowed to visit patients in the aged care facility. Subsequently, all of those aged care visits were stopped and are still stopped and being eased appropriately in each state, but that's where a majority of our deaths have arisen. Other deaths have come from the Alfred Hospital in Melbourne because it's a very high acuity facility taking care of public patients, and Northwest Tasmania, which again had a cluster, that small island at the bottom of Australia had a cluster in one of their public hospitals as well. There are a few other deaths which are the most deaths, which you can see at the bottom, which are still unknown based on their origin of where they've come from. So we're guessing that that is probably from community transmission and then resulting in deaths from that spread. In terms of our confirmed of active cases, you can see from the graph that Australia has so the dark line is the total number of cases. And you can see that we have basically been flattening the curve, that terminology that everyone has been using. Our curve has flattened in terms of the growth of the number of cases, and I'll talk about growth factor in a little bit. The orange line is the number of active cases, and you can see that has come down quite steadily. And you can see this very sharp decline, which I've put in a red box. As the government was monitoring a huge increase in rapid rate of growth in COVID, they quickly put in very strict restrictions in the beginning of April about social distancing, not leaving the house, travel restrictions, cancellation of elective surgeries, etc., which you can see were quite effective in the beginning with a sharp decrease in the number of cases and a continued decrease even until now as we're flattening the curve. I'll talk a little bit further about our restrictions on later slides, but one thing I do want to highlight now is one of the restrictions that did occur very early on was the cancellation of elective surgeries. So emergency surgeries and emergency departments stayed open at public and private facilities, but all elective surgeries were stopped according to the Australian elective surgery triage system. Obviously, this had a huge impact on our private hospital market, which is about 40 to 50% of the hospital market throughout Australia. Because the private hospitals make a lot of their patient occupancy and revenue from elective surgeries and then subsequently from patient stays in the hospital afterwards, this basically evaporated overnight when the government passed the restriction to cancel elective surgeries. So private hospitals were struggling for a few weeks after this restriction came into place. What we saw on the other end is that the hospital occupancy in public started to increase. And the government wanted to ensure that with this increase in COVID in the public hospitals that we relieved or basically released the pressure valve on those public hospitals to ensure that they still had flexibility to take care of emergency patients, ICU patients, and other COVID patients, as well as keeping their staff safe with reduction of overcrowding. So what happened was the government agreed with the Private Hospital Association of Australia to basically purchase beds and purchase services from the private hospitals so at public rates so that the private hospitals could stay in business with revenue and the public hospitals could decant lower acuity COVID patients to the private facilities and relieve pressure on the public system to ensure that it was still available and working appropriately for the Australian population. Now, in terms of the new daily confirmed cases in Australia, I wanted to show you this graph, which you can see these are the number of new cases each day. So we're sort of hovering now around 10 and under mark, which is good. But we've had some peaks over the 20 new cases per day mark around early May. And these, as I mentioned, were from a testing blitz in Victoria and some other parts of the country. If you were reading in the news, Cedar Meats, which was a abattoir and meat packaging facility in Melbourne, was actually one of the hotspots that was found during the testing blitz, and subsequently all of their employees have been asked to stay home and isolate to reduce the spread of the virus. And as I mentioned, northwestern Tasmania and aspects of the community started to be picked up in terms of hotspots for COVID from this testing blitz. So it's good to see that these number of daily cases is going down, but also it's good to also explain why we have some peaks and troughs throughout this throughout the days of monitoring. I also wanted to share with you where the transmission sources is coming from. So where is COVID coming from in the community? As you can see at the bottom, these different colors mean different sources. So black means it's coming from overseas. Blue means we know where it's coming from and it's local transmission. Orange means it's local transmission, but we don't know where it's coming from in the community. Green is interstate travel, and pink is currently under investigation. So as you can see, over time in the beginning, there was a lot of unknown local transmission in the orange bars, but a lot of those have been currently investigated and known and closed out. But we can see now, as you can see in the red box, that a significant amount yesterday, 25 cases are known local cases. So we're starting to understand more where these cases are coming from and finding out that they are coming from remaining community transmission, which is why we have been a little bit slower to release social distancing and restrictions in parts of the country. Overseas cases continue to occur, but they're at lower amounts. What Australia has done is prevent or restrict all travel into the country, except for citizens and permanent residents. And if you are able to travel back to Australia, you must go into mandatory 14-day hotel quarantine at a government-approved facility. So a lot of these black figures here in overseas cases are cases from hotel quarantine that are being picked up by government-mandated testing. Some other interesting things about travel is you can see that there's not much interstate travel associated with transmission of COVID. And I'll speak about this a bit later, but this is because states and territories in Australia have internally closed their borders. So that means while it's very difficult to travel into Australia, it's also equally as difficult to travel within Australia. So for example, myself in Victoria, while I can travel to Sydney, I cannot travel to anywhere else in the country like Tasmania, Perth, Adelaide, Brisbane, etc., because their borders are closed. And I'll show you that on a map in a little bit. This is also just a graph to show the figures around what I'm talking about in terms of the testing blitz. You can see the green dark line, which is basically the number of average number of daily cases. And you can see the peak in the beginning of March. And then as we've moved through the end of March into April, with all of the restrictions taking place, those average daily cases are coming right down. But the purple bars you can see, or the pink bars you can see, are the number of average daily tests that we're doing. So on the 24th of May, the country did 30,000+ tests for COVID in that one day. So you can see as the testing is going up, the restrictions are impacting on our average daily cases, which is going down. And thankfully, with the increase of cases, we're also seeing, with the increase of testing, we're also seeing that the average daily number of cases is about holding steady, which is giving the government confidence that the spread of COVID is in fact slowing down, and giving confidence that we can slowly ease restrictions throughout the country. This testing regime equates to about 5,200 tests per 100,000 residents on average throughout the country, which is quite a high rate, I believe, when you compare it to some other places in terms of rolling out our testing regime. This is an interesting graph which shows the history of implementation of restrictions as they were imposed in Australia, and the impact of those restrictions on actually decreasing the number of new cases per day. So you can see the red bars are the average number of cases per day. And towards the end of March, beginning of April, there was that big peak where around there were 400 new cases a day. Before that time, Australia banned all travel from China, then banned all travel from Iran, South Korea, Italy. Then they were reducing outdoor gatherings. But as you can see, there's a flurry of restrictions that happened during the peak of COVID towards the end of March, where all bars, restaurants, indoor gatherings, outdoor gatherings were closed down. Mandatory isolation for travelers occurred, expanded testing regimes, ban on traveling overseas, So basically, we just had to stay at home and nothing was open except for essential services, which is very similar restrictions to that were occurring in most countries. But very quickly, you can see from those restrictions being implemented in late March, early April, that our daily number of cases quickly reduced, which was a great result, which is why at the end of May, beginning of June, we're now seeing that long tail of cases and also seeing our restrictions being lifted. Now, I wanted to share with you a figure that we receive in the newspaper every day about what Australia calls our growth factor. So this is basically how fast are new COVID cases going up or going down. So it's good if that number is below 1, because that means new cases each day are going down and we're getting control of the outbreak. When it's above 1, that means it's increasing. So Australia at the end of May, we're currently at 0.96, which means the number of new cases is decreasing. We've had our highest peak in the middle of March, which basically links up to my previous graph showing you that that was the peak of our quickest growth in cases, but that quickly went down below 1 once we implemented all the travel and other restrictions. I wanted to just compare the growth factor of Indonesia at the same time as Australia. It's around 1.03, so a little bit higher than 1, but it seems to be holding steady around that, which is basically what you'd like to see, but obviously have that go down even further. We certainly understand that Australia has the benefit of being a very large country without very many people in it, which is the opposite from Indonesia. So we have had that benefit of having lots of distance to social distance within the country, but we understand there's difficulties in lots of different places in terms of really getting a hold on the growth of this virus. Recently, the Australian federal government, so our Prime Minister, Scott Morrison, has released from Canberra what the Australian government is calling a 3-step framework to a COVID-safe Australia. Basically, this 3-step framework is how we're getting Australia back into business and back into almost life as normal. I've included the link here, which you can find from the Health Department of Australia. This is freely available. I won't go through all of this detail, but basically what the government has done is given each state and territory 3 different steps to say hopefully by the end of July, we would like all of these different aspects of our economy and our society back open and back up and running with certain restrictions. And you can see what the government has done, everything from domestic travel, hair and beauty services, cafe and restaurants, retail, and how the restrictions are being eased from step 1, step 2, and step 3. Step 3 being to reopening businesses in a safe and COVID-safe way. Now, what the government has allowed, the federal government has allowed each state and territory to implement this 3-step framework at their own pace. So some states and territories may go through these steps quicker to get their economy open, while some other states and territories may go a bit slower and a bit more cautiously based on the testing results that they receive. And I'll show you now. This is, just waiting for it to come up on the screen. This is how each state and territory is now relaxing their restrictions. So yesterday, the box in the top left, you can see these are the number of days since the last reported case of COVID. So the Northern Territory has 26 days COVID-free. The Australian Capital Territory, where Canberra is, has 24 days COVID-free, Tasmania 12, and the other states 0 or 1. Each state, as I won't go through all of them here, but you can see there's variation in their easing of restrictions and what you can do in each state based on what that state government has allowed. So where I live in Victoria has one of the strictest restrictions still in place, where we can only now have 5 people gather in home and 10 people outside, but you can still only leave the house for essential reasons only. Restaurants are not yet open here, and police are strictly enforcing with penalties all of the current Victorian restrictions. Now, if you go over to the other side of the country in Western Australia, 20 people are allowed indoors and outdoors. Restaurants are allowed 20 people. Schools have reopened because they have been performing better than the rest of the country, given their low population and massive amount of space. But their borders remain closed. So as I've mentioned before, it's very difficult to travel within Australia at the moment. The state borders of Tasmania, South Australia, Western Australia, Northern Territory, and Queensland are closed. And if you travel into those states, if you're a resident of that state, you still have to undergo 14-day mandatory isolation. So what may happen is that if you fly back into Victoria, you go in 14-day isolation, and then if you're a resident of Adelaide and fly to South Australia, you go into another 14-day isolation in that state. This may seem a bit confusing, but what the states have done is really taken guidance from the federal government about how they implement and go about easing restrictions in their own territories and states. Interestingly, though, what the Australia and our friendly neighbor New Zealand are talking about at the moment is establishing international travel again into something called the Trans-Tasman Bubble, which basically means that you can travel freely without restrictions or requirements for hotel isolation between New Zealand and Australia. This has not yet been finally agreed between the prime ministers of both countries, but it's something that has been discussed frequently in the news and hopefully will be coming soon. There is a planned flight for the 1st of July, which will occur between Canberra and Wellington, linking the national capitals of both countries together very symbolically, and hopefully after that we see further travel between the two countries. Other South Pacific nations like Vanuatu and Fiji are also very eager to join the Trans-Tasman Bubble to encourage more tourism to those islands as Australia and New Zealand enter into the winter months. Obviously, they have been very impacted by basically elimination of tourism in their economy. As I mentioned before, if you come into Australia, you can only come into Australia if you're a resident or a citizen, and you must undergo 14-day manual quarantine. And even if you decide to leave Australia, you must receive permission from the Home Affairs government in order to leave and board your flight. So we've really quite restricted travel, as we found in the initial data that a lot of our cases were being transmitted by interstate and international travel. The Australian government has also released an application called COVID Safe, which is completely free to download. I believe there's about 5 million people across the country who have downloaded this thus far. Basically what this application does is run on your phone. So as you're walking outside and going about doing permitted activities, if someone is currently tested positive for COVID or previously tested positive for COVID, it will alert the application to say that you have been in the region of someone who is tested positive. If you've tested positive, your health practitioner will ask you to update your application with your positive test results, and then the government is able to contact everyone that you would have been in contact with to ensure that they monitor themselves for COVID symptoms. This is basically a way by the Australian government to even further improve their ability to contact trace as we get even further handle on the spread of COVID throughout the country. So this has been very effective and a huge uptake by the Australian population in terms of finding out how the virus is spreading and ensuring those people that may have come into contact go into isolation to prevent any further spread. Now, as we are both accreditation agencies, there obviously has been an impact on our accreditation activities. So in Australia, ACHS accredits organizations to the national standards, which are set by the Australian Commission on Safety and Quality in Healthcare. And as I mentioned before, we are one of 7 approved healthcare accreditation agencies that are able to accredit throughout the country. Now, the Australian Commission, when the restrictions were put in place, have put a pause on all on-site assessments that are required under our national scheme. They did permit off-site virtual assessments to continue, and ACHS has completed some follow-up, or what you call it, KARS verification surveys, but instead of doing those on-site, we continue to do those in the beginning of the restrictions through a virtual basis with our assessors dialing in to the healthcare providers. Since then, though, we have not been able to conduct any domestic surveys, as the government has not released or permitted any of those to continue. Now, internationally, we have a bit more freedom, but obviously need to monitor the situation across the 15 countries in which we work. We have already implemented virtual assessments in the Middle East and Asia Pacific with a mixture of local on-site assessors that can travel in their home countries, connecting back to lead assessors and our assessor cohort here in Australia to have a mixed or basically a hybrid approach to on-site and virtual assessments as we continue those throughout the world. We have created a resumption plan to get all of our services back up and running internationally, based upon travel restrictions once they're lifted in Australia, and also based on local laws and regulations of each country in which we work. So it's a big undertaking, but we do want to ensure that we're keeping the spirit of continuous quality improvement alive and helping our healthcare organizations with as much support and guidance as possible from Australia. Now, I just want to end on my last slide on a positive note around what are some innovations that we have been doing at ACHS International while we have been given the time to basically pause from not doing domestic or international surveys in some respects, and really think about how we can innovate our business. So during this time, it's really giving us a new opportunity to adapt to our virtual world and build up opportunities for innovation. What we've done, as I mentioned before, is increase the number of virtual assessments and our hybrid assessments with our international and domestic assessor cohort. We're also developing our new set of standards under EQIP 7, which has taken a completely innovative approach, modular approach to how we create standards and implement that across the world as well. We've also created a host of supportive services that we've released complimentary to all of our members, like a COVID Resource Center online and other member and coaching services, to ensure that while we're not doing assessments, there's still an opportunity and a connection to support ongoing improvement to standards and recommendations that we have given organizations previously. And finally, we've been doing weekly virtual assessor training through assessor forums and through assessor feedback, very much like you're doing through Dr. Henny and Dr. Sototo at KARS, to keep everyone, while you're working from home, still connected to the environment of accreditation and quality improvement, and doing the same thing with a lot of virtual meetings with our members to continuously assist them with guidance and other documentation as they progress and navigate this time of COVID response. So I want to thank everyone for listening to that. Hopefully it was a helpful presentation and shed some light on what we have been doing here in Australia. And obviously at the end of the panel, happy to take any questions from the group. So what I'd like to do now is just hand it over back to you, Dr. Henny, and looking forward to questions at the end.
Okay. Well, thank you very much, Michael, for your superb presentation. Now we turn to Professor Kadar. Please have your time.
Assalamualaikum and a very good afternoon. Thank you, Dr. Hani. Thank you, Dr. Sototo, for inviting me to join this webinar as well. And hello, Michael. Nice to see you. Now, what I'm doing is just to share what we have been doing and how Malaysia have been managing the COVID-19 cases. Can I have the next slide, please? Oh, okay. Now, the spread of COVID-19 in Malaysia. Virus was confirmed in Malaysia since January 2020. It was detected on travelers from China arriving via Singapore on January 25th, following an outbreak of COVID-19 in Hubei, China, province in China. The numbers continue to be low until March 2020 and mainly confined to imported cases. Now, after March onwards, we actually started having clusters emerging, and the largest ones linked to the public Jama'ah, a religious gathering held in Sri Petaling Mosque in Kuala Lumpur, and in the late of February and early of March 2020, with over about 16,000 participants, including over 1,000 from other countries in the region. So this actually has led to massive spikes in local cases and exportation of cases into the neighboring countries. So by March 16, the virus was reported in every state as well as the federal territory. Now, this is what our statistics are at 28th May, 5 p.m. yesterday. We are due to have another press release this evening at 5. Now, the current total infections is 7629, just something almost similar to Australia. The total discharges so far is 6169, and we have got a slightly higher death toll of 115 compared to Australia 104, I think. Now, and yesterday we had only 10 cases. We hope today we'll have a single-digit number of new cases. And in fact, that 10, 5 were actually from immigrants and 5 were from local. And we have got a total of 1,345 currently under treatment. And our case fatality rate we look at is 1.5%. Now, what are the challenges that we have? The outbreak was actually at a time of a major political crisis in the country, with the resignation of the 7th Prime Minister, Dr. Mahathir Mohamad, and late of February 2020. And this actually also resulted in the crossover of a few of the current ministers to join the opposition party. So the swift, that is actually, there were no really, the government was not attending to COVID cases at that time. They were much more interested in the political issues within political crisis at that point of time. So it was actually an overlap during the same period. However, the swift action taken by the King was able to restore the new government with the appointment of a new Prime Minister within the government, which is a new government that under the Perikatan Nasional that was on the 1st of March 2020. However, at the same time, while all these political crisis is going on, we luckily have got a good stewardship from the Director General of Health, who continued to provide his role to monitor and provide directives to manage the COVID-19 pandemic during these political crises. That actually have stabilized and helped us to move forward. Next. Now, the activities that we have, I'm just highlighting some of the major points of what actually have transpired over the days, and I've actually summarized some of the strength that we have and some of the major approaches that we have taken to actually bring down the number of COVID cases in the country. One is the continuous commitment and dedication of the Ministry of Health leaders, shown by the leadership from the Director General of Health to cut the chain of transmission of COVID-19. Every case that we have is numbered, and immediate active tracings and follow-up with testing were carried out until today. Regular updates, reviews, and communication of case management and SOPs to commensurate with latest available evidence from World Health Organization. MOH also identified dedicated public hospitals as referral centers in all states to manage COVID-19 cases, and all elective cases were transferred to either the other public hospitals or private hospitals. So the dedicated hospitals will not be looking at other elective cases, just dedicated for COVID-19. Now, a 14 days quarantine was enforced for all contacts. Dedicated quarantine centers were identified and were put into operations. We have 3 major centers within the KL region. The Director General of Health also provides daily updates press release at 5 p.m. every day in the national media to keep the public well informed of the COVID-19 scenario within the country. MOH also optimizes the capacity of all public hospitals so that we can mobilize and deploy our own experts should the need arises. So this is about maintaining good use of our resources in the public sectors, because all cases will be treated, all COVID-19 cases generally be treated in the public hospitals. Even if the private hospitals receive COVID cases, they will refer them to the public hospitals where the dedicated hospitals have been identified. Next. Now, at the same time, lab testing increases from time to time, and almost concurrently, we also were looking at the health and well-being of other citizens. Those feeling unwell during the self-isolation can find out if they are at risk via self-assessment link with the MOH, which is done in partnership with Doctor on Call via my Sejahtera app. So this app is available, can be downloaded. So those who are at risk can contact MOH doctors by clicking Ask Doctor button on the app as well. If risk assessment results are high, citizens are advised to contact the nearest MOH hospitals available for support. Now, MOH also identified a list of private hospitals providing laboratories and e-medicine screening services at a cost is also available. Panel doctors for consultation is also available online, and counselors are also available for those who need one. So this is an emotional support if needed by any of the citizens. Now, the resources, information and data around COVID-19 are available on the Malaysian Ministry of Health website. This is the most reliable source, and we encourage providers, citizens actually to go into MOH website and do not get themselves confused with the many misinformation that is circulating around the country. Now, daily updates and press release actually helps a lot to all the citizens, and in fact, the DG is now a big celebrity within the country. Everyone seems to be able to identify him. Now, fighting misinformation. This is another major concern where everyone have got a handphone. People send viral informations, fake information. So we need to make sure that this is being curbed. So some people have been arrested for allegedly spreading false or fake information. Police and the Malaysian Multimedia Commission has opened up 265 investigations on COVID-19 related to fake news. A total of 30 people have been charged, 11 served with warning, and 18 pleaded guilty. So that is going on until today. Now, priority, the second issue that I'm trying to highlight now is the priority given by the government to curb the spread of COVID-19. As you know, it all happens during the political crisis in the country. However, the present government were able to take measures, step up the role, and get conditions into control. So on the 27th of February 2020, that is the earlier government, they actually have introduced an economic stimulation package to ensure the economic risks related to COVID-19. However, on the 16th March 2020, with a new PM, he also announces additional measures to enhance economic stimulus package 2020. And on 23rd March, RM 600 million was given to Ministry of Health to purchase equipment and hire contract personnel to boost up the human resource to help to support to address the needs of COVID patients. Next slide. Now, on 27th of March 2020, a second economic stimulus package worth RM 2 billion was also provided to strengthen the economy, well as necessary measures to provide assistance to all Malaysians who are affected by COVID-19 outbreak, because at that point of time, people are all under MCOs. So no one is allowed to move around unless they are from the essential services. And on the 6th of April, additional commitment from the government, there's another 10 billion were given, aimed at helping business, in particular small, medium industries, to pull through the challenging period. Now let's move on to the movement control order that was implemented. The first one was announced on the 16th of March 2020. Following the spike of cases, the PM announces the movement control order to curb the outbreak, and the first MCOs was from 18th of March to 31st March, and it was effective nationwide. And that actually prohibits overseas travel for all Malaysians, and no visitors are allowed into the country. And at the same time, closure of all government and private premises except those providing essential services. The second phase, on the 25th of March, the PM announces that the MCO have to be extended until 14th of April 2020. Subsequently, with the cases still not coming down, they've not been able to flatten the curve. So the third phase of MCOs was released, and the PM announces an extension until 28th of April 2020. Though the number of cases were going down, however, it's still not stabilized. So the PM announces another extension of the MCOs until 12 May 2020. Further to that, on the 11th May, the PM announces another extension until 9th June 2020. Though the cases are coming down, but they're still not confident enough with the decrease. So the Ministry of Health advises that this needs to be extended until 9th of June 2020. So now all of us are actually waiting for 9th of June to see whether the MCOs can be uplifted, or whether more other services can start functioning. Now, however, on the 4th of May 2020, the government actually eased the lockdown to conditional MCOs. Well, the cases are going down, and we feel that we should be releasing these MCOs slowly and incrementally. So as such, on the 4th of May, they announced from 10th May to 9th June 2020, they will reopen the national economy in a controlled manner. This will allow certain business sectors to resume operations following the stipulated rules and SOPs provided by the Ministry of Health. So this has been going on until now. And as you all know, we had our Eid al-Fitri, where people usually balik kampung, everybody wants to go back to be with their families. All these have not been allowed, it's been restricted. We actually promote strong border control. Can I have the next slide, please? Now, we have strong border control. No one is allowed to go beyond the states. And the police, as well as the military, guards the borders from every state. So no one could cross the state without prior permission or prior approval from the police. So people are encouraged to work from home, practice social distancing, never to leave home without valid reason, and only one member of the family is allowed to buy essential food or medication. All tourists were banned. So we have actually quite a strong enforcement in social distancing, and also people going out, and people are not allowed to move more beyond 10 kilometers radius from their own home. So that actually have kept things going, and it has helped us to reduce the number of cases. And at the same time, all Malaysians coming home from overseas were tested and quarantined for 14 days before they are released after the test is negative. Strict international border control, especially with Thailand, with Singapore, and also our waters. Only the first day of it is allowed for close families within the same state, but not more than 20 people. Practicing social distancing should be maintained. Tight enforcement by enforcement officers. Fines were issued in the event of non-compliance. So this has been going on, and enforcement on border control are done by military as well as police personnel. And to date, we have noticed that 95% of our citizens actually comply to the requirements of the MCOs as well as the SOPs, and they only about 5% non-compliance, and perpetrators were taken legal action and compounded as well as they were fined. So this actually have helped us a lot in reducing the number of cases within the country. Now, what are other supports that we have to curb the spread of the disease? Between Malaysia and other countries, from January to February 2020, Malaysia actually supported China. We sent them 18 million pieces of gloves to China, while in March to April, during March to April, we actually received supplies of face masks, PPEs, and disinfectants from China. And we also had received aids from UAE. They supplied face masks, ventilators, test kits, and PPEs. At the same time, local donors, agents like McDonald's also provided 15,000 of fast food to our frontliners. So there's a lot of support from local NGOs to manage the concerns of the public. I think we have got quite a number of people who were on daily wages. They definitely have got problems with finding food to put food on the table. So we have got a lot of support, donations coming around to help people, the citizens. At the same time, the local pandemic fund was established, and the PM and the ministers actually initiated with a 2-month salary cut to support the national COVID-19 funds. At the same time, various banks also provide financial assistance for its customers. Local broadcasting and telecommunication companies also to ensure and also to keep the public entertained during the MCOs. Pay televisions were provided free of charge. Free internet services with high-speed data were provided. Numerous local NGOs also provide support to frontliners and the poor and other community needs. So these are some of the activities that have been put in place to support the whole implementation and management of the COVID-19 in Malaysia. So we hope we'll be able to cut down and get into our daily lives as soon as possible. So we pray to God that everything will be going on fine, and we all there's a great emphasis that all of us should be socially responsible and accountable to prevent the spread of the disease within the community. It's coming that everybody's business is our concern, and we need to address it. And at this juncture, I would like to acknowledge the Government of Malaysia, Ministry of Health, and all other relevant ministries, frontliners, international and local donors, and the whole population of Malaysia for complying to government MCOs and SOPs in our fight against coronavirus. So our hashtag is we take care of ourselves. Thank you very much. I've got actually a second presentation, which is around 8 minutes. Maybe Dr. Hani will help us to present the video. And this is actually a report from one of the foreign reporters about how Malaysia have managed the COVID-19 cases. Thank you very much.
Thank you very much, Prof. Kadar. We are going to see the video about Malaysia. Please, Pak Indra.
Imagine your country is going through a huge political crisis. You have a new leader, and several states have new governments. Not only is your country facing political crisis, but also economical.
Yeah.
And the worst thing that could ever happen
Share gambarnya ya. Oke.
It's Malaysia. Malaysia was in some serious trouble. But don't you ever underestimate the power of
Sound is
Malaysia.
not good.
Sound not good.
Sound is not good.
Hmm.
It's not coming out.
Suaranya keluarin.
No sound.
Here are 15 ways that Malaysia did the impossible. Number 15, donations and volunteer organizations. So many people volunteered and so many organizations helped out. For example, Amaret provided healthcare workers with food, AC units, and raised over 3 million ringgit for medical supplies. Number 14, top doctor. Dr. Noor Hassan Abdullah has been ranked one of the top doctors in the entire world at fighting the coronavirus. And not only does he present accurate facts, he's able to do it in a way that gathers support and also keeps people calm as he does it. Number 13, the movement control order and the enhanced movement control order. These things are not easy to pull off, and it took so many people in different organizations to work together to have them work. Number 12, indirect volunteers. There are so many people that helped out and volunteered and did so many different things like food delivery. Number 11, building temporary hospitals. Malaysia was able to build temporary hospitals very efficiently and quickly. For example, the largest agro park in Asia was able to be built into a hospital in 3 days. Number 10, the two-play cluster. The two-play cluster complied with any order from MOH, and they never complained, even though they had to wait long hours in the heat. Number 9, banks. Banks lent to the borrowers for 6 months. Number 8, universities. Universities allowed schools to stay for free, provided the food as well. Number 7, stipends. Nearly 4 billion homes received up to 1,600 ringgit. Number 6, ignored politics. Opposition leaders came together and forgot about politics for the good of Malaysia. Really cool. Number 5, protecting the most vulnerable. Malaysia did a great job of protecting those that were most vulnerable, homeless and foreign workers. They were put in public halls and provided a tent. Number 4, Malaysians returning home. Malaysians returning home from overseas were provided a free hotel, free food, and COVID-19 testing during their 2-week quarantine. Number 3, respect for frontline workers. I've never seen so much respect and love for frontline workers. It was so beautiful to see all the support Malaysians gave to the frontline workers. Number 2, fixing the PPE shortage for frontline workers. At the beginning of the crisis, there wasn't enough PPE for all the frontline workers, and so Malaysians took it onto themselves. For example, a fashion designer realized she had a skill set that could be very valuable, and so she took the initiative to organize an entire team to make PPE. Prisoners made PPE, college students made PPE, even a Malaysian born with no arms didn't let that stop her from making PPE. And number 1, most important, is teamwork. It doesn't matter if you're a celebrity or an average person. It doesn't matter your social status. It doesn't matter your gender, your religion, your ethnicity. All Malaysians came together for the better of Malaysia. And that's how Malaysia was able to do the impossible, to go from a country that had 3 times more cases than any other country in Southeast Asia to now be one of the safest countries in the entire world. And lastly, I'd like to thank all the Malaysians that helped make this video possible. So many of you wrote to me and sent me videos and pictures. And specifically, Pacific Maku, who's a motorcycle rider, let me take lots of his footage, along with Q Productions, who took beautiful drone shots. You can find links to their channels in the description. So thank you to all of you who helped make this video possible.
That's it. Yeah, thank you.
Apologies for the sound is not good.
Yeah, the sound is not good, but the picture is okay. Dear webinars, if there are some questions for these two experts. So, of course, Indonesia cannot be compared with Australia or with Malaysia because we have so many people, so very heavily inhabited. This is some questions. Michael, my name is Desak. Desak is one of our surveyors. I want to ask you, would you please share your experience how to conduct hospital accreditation during COVID? I think you have mentioned it a little bit. Maybe, and the second one, what is Australian government policy towards independent isolation, especially for people returning from abroad? Are there threats of fines or revocation of passport, for example? Thank you in advance.
Sure. So thanks for those questions. Dr. Henny, you want me to answer these now?
Yeah.
Sure. So in regards to the first question about sharing experience about how to conduct hospital accreditation during COVID, obviously we needed to increase and really think about the logistics of doing a hybrid model of virtual and on-site assessments. Previously, we have done virtual assessments domestically and internationally before COVID came into place. But obviously now with COVID, there are much more restrictions in terms of ensuring the safety of our assessors and obviously the safety of staff on site who we are accrediting. So what we've done is really improved our safety systems for assessors in terms of what they can and cannot do and checks that they have to do prior to any travel. But more importantly, what we've done is really invested in technology to create a hybrid system of local assessors who may be on the ground. This is particularly internationally. And those local assessors working with a LinkedIn virtual assessor, very much like we're doing now, to ask questions, do tracers, review documents, so that we're creating a hybrid mixed team of virtual and on-site people as well. So that really has worked in our favor with our local assessors throughout the world to get that connection. But obviously it is still takes a lot of getting used to in terms of ensuring the rigor and the integrity of the accreditation process when you're not actually physically there, being able to interact and freely move around a hospital facility as you would if you were physically on site. So what we've tried to do is through our weekly training of our assessors who are going to virtual assessments, ensure that they're aware of all the safety measures that need to be in place, and importantly, be aware of how they interact with their buddy assessor who is on site internationally and how they work together to plan out the assessment, how they ask questions differently, and how they interact with staff differently. Now in Australia during COVID, as I mentioned, we can't do any on-site assessments at all. So we're not doing really any virtual assessments because no one is allowed on site at hospitals or healthcare facilities unless you work there, which has been an order from the Australian government. But this is certainly a great question as how all of us across the world as accreditation providers had to quickly respond to a pause on our services and ensure safety and the integrity of our programs. So hopefully I answered that question for you. The second one in terms of the Australian government policy towards independent isolation. So I'll take these in two parts. So anyone who is traveling from abroad back to Australia are only allowed to be citizens and permanent residents. And those people must go into mandatory isolation. So you're transported by the government from the airport when you arrive to the mandatory quarantine at a hotel, stay there for 14 days without leaving your room, and then you're allowed to go back home. And you're continually monitored to ensure the symptoms with free testing don't appear. For those people that weren't traveling, self-isolation was only for essential services, and this was monitored by both the Australian Federal Police and the state and territory police, very much like Malaysia, that would do random checks on households and on gatherings to ensure that you were only with people that you lived with and that you weren't actually going against any of the restrictions. And fines varied per state, but they were usually about $1,000 Australian dollars per offence per person. So there have been lots of instances in the news where people were fined almost $20,000 for breaking those restrictions. So that's how we were able to implement and enforce a lot of the self-isolation rules. And then obviously, even if you had to go to the supermarket for essential services, there would be screens up to prevent to ensure the safety with workers. There'd also be docks on the ground to ensure everyone was spaced correctly, increase cleaning, etc. as well. So to ensure safety of people who did have to still go out for those services.
Thank you. And any more questions? Any more questions? Yes. For Professor Kadar, how does the Malaysian government direct towards community understanding to support isolation and maintain social distance? Thank you in advance.
Thank you for the question. Can you hear me?
Yes, yes, good.
Okay. Now, in every district and in every 5-kilometer radius in Malaysia, we actually have got the clinic centers, the health clinic. So actually, the staff who are working within this clinic actually provide support during this period to provide education, information to the local communities. And in fact, there's an extensive amount of information being shared within the country. And in fact, every other day, there are information being released, announced publicly for the public to actually be able to understand the SOPs that has been provided, approved by the government for everyone to comply with. And in fact, we had a study to show that out of the whole population, actually 95% really complies with the SOPs, and there were only about 5% recalcitrants who actually defy or fail to comply to these requirements. And the other issue is also about sanctions and regulations and act. We have got the Infectious Disease Act, which actually governs the whole citizen, and it is being implemented now. And we also have got the Police Act. So these two acts actually governs the whole activities of social distancing and making sure that SOPs are being complied and no crossing borders. So all these are actually being maintained and is being actively done by frontliners from the military as well as from the police people. So these actually have helped us a lot in improving the situation around the country.
Professor Kadar, can you tell us how big, how much does people have to pay fee or fine if they broke the
immediate compound of 1,000 ringgit.
1,000 ringgit.
Yeah.
1,000 ringgit. In Australia, yeah. 1,000 US, 1,000 Australian dollar.
So 1,000 ringgit is about 3 to 4 million rupiah, maybe.
3 million rupiah, yeah, and
3 to 4 million.
3 or 4 million, and in Australia it's 10 million. Yeah,
10 million.
In Saudi it's 10,000 real.
Yeah,
10,000
yeah,
real.
that's very expensive.
Yes.
Don't go outside.
Saudi are tough people, so they need more.
Maybe somebody wants to ask directly. Pak Indra, can you see? Maybe before. Yep. Okay. Somebody want to ask? Tell your name first. It's bad weather, Michael. Here it's raining very heavily, so maybe
it's raining there.
Oh, that's not good. It's very cold here in Melbourne at the moment, but we've had beautiful weather today. We're getting ready for winter time.
Can I ask you one question, Michael, about the enormous testing that you have? Is it a rapid test or is it PCR?
They were doing a mixture of both. They wanted to rely on the more reliable PCR test, So that's what was occurring at the COVID clinics at the designated hospitals throughout the country and other designated COVID clinics. So it was quite a rapid turnaround because all of those were urgent when they were sent to the pathology labs, which were put on alert to get those back quickly. In other cases, if we needed a more rapid response for isolation, they would do the rapid test, but those were very limited. I always had, when I arrived back in Australia from traveling, I always had the PCR testing done.
Okay, and do people have to pay for the PCR? How much?
No, so all pathology testing in Australia is free under our Medicare National Health Insurance. So there's no payment for any COVID testing.
Oh, thank you very much. This is to Professor Kadar from Dr. Leo, is obstetrician.
Thank you for the question. Now, I think we have got 1.51% mortality, case fatality rate. Now, from this 1.51%, actually about 60% of them are elderly population with comorbidities. And our line of treatment is actually the same as what have been advised by WHO, anti-inflammatory, chloroquine, acyclovir. These are the sort of drugs. There's no specific, but these are all working on anti-inflammatory issues, symptoms that we could do. So it's actually the physicians also look at case by case, and guidelines are made available, and it is being updated day by day, depending on the progress and advancement and learning from the experiences from other countries. In fact, we also brought in experts from China, from Wuhan area, to actually support us to see how we could actually provide a better case management in our all our COVID cases. So that actually have also supported in the low case fatality rate within the country.
Okay.
I just wanted to add from the Australian perspective, because I think that's a great question from Dr. Leo. We're doing very similar to Malaysia. Obviously, our fatality rate's around 1.4, 1.5, so very similar. As Dr. Kadar said, the majority of those deaths are in the elderly with comorbidities, sort of equally split between men and women as well. The chief health officer has advised against using hydrochloroquine and chloroquine for any treatment for COVID. There have been tests using Gilead's remdesivir, which was used for the Ebola outbreak in Sierra Leone as a potential treatment to see if that would impact and show some effect with COVID. And very similar to Malaysia, we are released updates every day from the Federal Health Department on guidelines for treating COVID. The University of Queensland is also trying to accelerate through human trials of vaccination that they are testing in Queensland for across the country. And there is also moves to start using convalescent plasma from people who have generated antibodies for COVID-19 to see if there is an impact on those people still testing positive. But thankfully, the restrictions, very much like Malaysia as well, have come down to very few cases. So hopefully we don't have to implement much higher, more intensive interventions.
When are you going to loosen the tight isolation? June in Australia?
So as I mentioned in the presentation, it depends on which state you live in. Some states already have loosened restrictions. Where I live in Victoria, the majority of the restrictions will be loosened on the 1st of June, but it won't be everything. But at least there will be more interaction with other people that you don't live with. And there's more activity certainly in the cities at the moment in terms of traveling and getting back to the workplace.
Australia, Melbourne and Sydney, yeah, got postponed.
Yeah, yes, Melbourne and Sydney were the ones that were most hit because we've had the most population and the most travelers coming into those airports.
Okay, thanks. And Prof. Kadar, what's the schedule to loosen
Waiting for 9th of June, the announcement from the government.
9th of June, okay.
Yeah, but we are still not sure whether it's going to be lifted or is it going to be extended. So hopefully with the reduced number of active cases now, and the new cases are also very much reduced. Hopefully today we can see a 1-digit figure. Hopefully if that comes through, then inshallah it will be lifted by 9 June.
Yes, dear listeners, webinars, we can see that from the two expert presentation that the success rate in Australia is very good. Also in Malaysia, where the graphic is already down near very good. Hopefully Indonesia can follow them soon. Any more questions? Dear Professor Kadar, from Dr. Nico.
Thank you, Dr. Nico. How are you? Now, currently, MSQH is actually under total lockdown. We are not part of an essential service, so we are not allowed to do any surveys. We have not started anything yet. We're just waiting for the 9th of June to be to allow us to go back to office to start working. However, during these MCOs, we have been having working at home, and we have been having discussions and preparing drafts for our training program, as well as how to conduct our surveys. But all these will have to wait until we go back to office, and we may need about 2 to 3 months before we can resume our activities, because it's not just us to be prepared, but our clients also need to be prepared in the event that we are going virtual. So they must have the resources as well to comply with our requirements. So all this must be met before we can actually actively start our training programs, as well as our on-site surveys. On-site surveys definitely will be very much reduced, and there are certain requirements that needs to be addressed before we can allow our surveyors to go on site. Majority of our surveyors are more than 50 years old, so they are under the vulnerable age groups. So this is an area of concern. We're actually looking at ensuring that they have a test and they be negative before they go on site. We need to actually cover them with insurance requirement as well, if necessary. Otherwise, to ensure that they are safe at the end of the day. So I think there are a few things that we have been still on drafts. We have not really confirmed. We have not started. In fact, we have stopped doing training and surveys since February, even before the MCOs. We are anticipating that this will happen, and we do not allow our surveyors to go on site after February.
Prof. Kadar, some questions. What about the hospital that is due to their?
We actually allow them to ensure that we request them to continuously comply. In fact, I actually published a paper on how to ensure continuous compliance with the standards, so that you can actually maintain your safety of your staff, especially, as well as your patients. So that must consistently be addressed, even though if your accreditation have expired. In fact, for those all hospitals that are due for surveys during these periods, we actually give them an extension of 3 months. So hopefully 3 months, but we can actually provide another 3 months extension if the MCOs is not over yet, to ensure that they still continue to be in the accreditation status. So that has been our policy.
What about you, Michael? What about the hospitals that is due to accreditation at that time?
Yeah, very, very similar, exactly the same as Malaysia. Because we cannot go on site here in Australia, we were giving accreditation extensions around the 3 to 6 month mark, depending on when accreditation was redue for on-site assessment, to ensure that we received the all clear from travel restrictions and from the government to allow back on site. So yeah, we're following the same approach as Malaysia. So quiet times at the moment in the office.
Yes, thank you. Any more questions? Okay. There's no name here. I would ask, how did the number of non-COVID patients visit the healthcare during this time?
Now, as far as for Malaysia is concerned, we have got two types. One are patients who are on continuous treatment, chronic patients. Actually, we are promoting delivery of drugs for the continuation of care through postal. So clinics and hospitals are sending the drugs to their houses to ensure that they continuously get their supply of medication. At the same time, for emergency cases, we do have, but I think the number of MVAs we notice have actually very markedly reduced during these MCOs, as people were all confined to homes, so not much traveling. So accidents and vehicle accidents, all that have actually very much reduced, and even trauma, even emergency have very much reduced. And patients are not going. In fact, we do not allow patients to go and even visit patients in the hospital, families to visit patients in the hospitals. So all these actually have been barred, and hospitals are generally closed to visitors for during this period. Unless they have emergencies, we do still attend them, but they are be directed to certain hospitals that that can provide the emergency services.
Professor Kadar, do you divide COVID hospital and non-COVID hospital in Kuala Lumpur?
Yeah, we do. We have identified dedicated hospitals just to attend COVID cases, so they don't attend any other cases. All cases will be redirected to other non-COVID hospitals. Every state, we have got one COVID hospitals dedicated for COVID.
And you, Michael, same?
Yeah, so the very similar approach to Malaysia as well. We've actually continued with obviously essential emergency services and trauma, but have seen those presentations obviously decrease slightly. Very similar approach to Malaysia as well, with dedicated facilities in each state who are the dedicated trauma centers anyway for taking care of quite serious cases. What the government is nervous about, though, is once restrictions start to ease, that people or patients would have avoided going to hospital for some treatment out of fear of COVID spread. And they're thinking once the ease of restrictions are lifted, that there'll actually be an increase quite drastically in a lot of those non-elective cases of people now getting confidence to come back to hospital. So people, the system is planning for how do we get another peak in terms of demand back on the healthcare system, getting back to normal from the COVID peak. Similar to Malaysia, we're doing a lot of deliveries to home for patients who have had chronic diseases like dialysis, trying to shift that from hospital clinics to at-home dialysis as much as possible, chemotherapy and all those other treatments that are required on an ongoing basis with medication delivery and etc. We've also have increased services across the country in telehealth, everything from mental health to just basic checkups in primary care. That used to only be partially subsidized by Medicare, which is our national health insurance program. But during the time of COVID, that is now fully reimbursable from Medicare, so fully free for everyone. So to ensure that we have continuity in people's care, telehealth is made free for everyone, and all the GPs and all the way to some acute settings, telehealth is being used to manage the continuity of care for patients as well.
Okay, thank you very much. Telemedicine is free, yeah? Any more questions? If not, Dr. Sutoto, can you close the session? Thank you very much for Malaysia and Australia, two Commonwealth countries around us with their very suburb effort for COVID. Please, Dr. Sutoto.
Thank you, Dr. Hani. Dear KARS webinars, this time the webinar viewers were 367 people. Thank to the viewer for the attention. At last time depart us, and we have to end the webinar to saying sincerely grateful appreciation to the both experts for their very useful knowledge transfer. and we pray to God for their healthiness and success. My dearest friend, Professor Kadar Marikar from Malaysian Society for Quality in Healthcare, and Michael Giuliano from Australian Council Healthcare Standard. May God bless you. And once again, thank you very much.
Thank you.
Thank you for having us. Thanks, everyone. Stay safe.
Monday.
Yes,
Michael.
I'll see you Monday.
Okay, see you.
Yes.
Bye-bye.
Thank you. Bye, everyone.
Thank you, everyone.
Thank you, Mike. Thank you,
Michael,
Annie.
thank you. Yes, thank you.
Thank you.